motor neuron disease for about 10, maybe 15 years, depending on whether or not you focus on the studies we do in the lab versus the studies we do in the clinic. I'm joined today by two of the members in our team, Jeryn. Jeryn's doing a PhD with us, and also Ange, and Ange oversees the clinical trial that I'm going to talk a little bit about. When I was asked to speak with you this morning, I was given an opportunity to talk about our research in general, but also to tell you a little bit about a clinical trial that we're running and kind of the thinking behind the clinical trial. Now, you know, this is not meant to be a formal presentation, so if you want to interrupt and ask questions during the discussion, just do so. Happy to stop and give you some more information or to clarify something. We speak a lot to people with MND, so hopefully my language is appropriate in terms of what I'm saying. But if I'm talking about something you haven't heard before, or I'm going on about something that you've heard many times before and you want to move on, just move me along. There's really no problem with that at all. So our group, as you can see by the fancy slide, we call ourselves the Heterogeneity in Neurodegenerative Disease group. What we mean by that is all people with MND are very different. What we're trying to do is understand those differences and then use that knowledge to see if we can improve outcomes for everybody with motor neuron disease, regardless of the subtype of motor neuron disease that they have. And because of that, a lot of our research projects are focused on areas of MND that people don't normally consider. Now, and again, this is very common to everyone. We know that all MNDs are very different. There's a whole range of MNDs. So if you think about MND, my pointer's not coming up, so see if I can get a pointer for you. No, that's okay. So if you have a look at the picture on the left-hand side, there's a whole bunch of people standing there, and they've got little parts of their body shaded in with different colours. That really is what, at least in 2014, what we consider to be the spectrum of motor neuron diseases. And you can see that, you know, on the left-hand side, we have this thing called LMN, and on the right-hand side, we have UNN. That just refers to the lower motor neurons, the motor neurons that's in the spinal cord, and UNN is the motor neurons that are in the brain. And so the little picture on the right-hand side just illustrates one of those pathways through which the brain communicates to the muscles via the spinal cord, and it kind of illustrates an area of the brain that controls movement and how that movement then trickles down through connections into the spinal cord, and then connect areas in the spinal cord, and then how that information is sent out to the limbs and so forth. And all the different types of motor neuron disease that we have is really defined by whether or not the neurons in the brain is affected or the neurons in the spinal cord are affected, or if both of those neurons are affected. So for example, if somebody receives a diagnosis of ALS, it means that clinically they have signs of, you know, loss of neurons in the brain, but also loss in neurons of their spinal cord. Whereas somebody is diagnosed with something like PLS, it means that clinically they only present the signs of having loss of neurons in their brain, and their spinal cord is largely unaffected. Now, this is important because obviously for the person living with MND, it means that they are going to present very differently in the clinic, but they're going to have very different challenges as well associated with MND. And from an MND researcher's perspective, it also means that how we work with those people will change, because how they cause the disease progresses and how long they have with us as a research participant will also change dramatically. Generally speaking, people with PLS may live a normal, healthy life up until old age, although some people with PLS may also progress really fast and may pass away much earlier than is expected, whereas people with ALS tend to have a more rapid course of disease with a steeper decline in their functional ability. And so all of these things are really important for researchers, but also it's really, really important for how people with MND receive care. And from a research perspective, we want to learn about these variabilities, these changes, so that we can then take that knowledge and use it to improve the lives of everybody with MND, regardless of the subtype of their disease. And so really our goal as a research lab is to improve our understanding of this variability of MND, and of course all those other factors, not just the factors associated with where motor neurons are dying, but all the other factors that can have a big impact on their progression And then second to that is use that knowledge to target these factors to see if we can slow down the progression, improve the quality of life, and extend survival for everybody with motor neuron disease. Now, that's a big area of research. And so naturally over time, that's evolved into us running 4 major research studies. MEND, MND, which is a study looking at how people use energy in motor neuron disease and how that impacts things like their body weight. We, from that study, developed a study called EAT for MND, which is looking at appetite, but also mechanisms that regulate appetite in MND. And this is very important because we found that people who lose appetite and subsequently lose weight in MND have a more rapid progressing course of disease. And that most likely is because MND is impacting other areas of their brain. So loss of appetite is not just because people have had a diagnosis of MND and they're struggling to deal with it, and it's not just because they're having difficulty in swallowing. We're also conducting studies called digitals, which is really looking at connecting with people remotely to improve how they interact with their doctors, but also we can collect information remotely, which improves how we monitor progression, but also design things like clinical trials. And then the Belong study, which is a study that started this year, which is really reaching out and looking at people with slower progressing, longer surviving types of MND to see if we can learn from those MNDs, like PLS and PMA, to see if we can actually improve our understanding of ALS itself. And Jeryn is actually here today to talk about Belong. If you have any questions about that, or if you want to be part of the Belong study. Now, I'm actually here in large to talk about, sorry, just trying, my pointer still doesn't work, to try and talk about this thing called Metflex. It's that big thing in red. Metflex is a clinical trial that's evolved from all of the information we've generated through the MEND MND study. And so I'm going to just provide some justification for why we are running this clinical trial before I run into a quick overview of what the clinical trial looks like. There's no feedback because you all have muted, but just very quickly, has anybody listening today experienced weight loss or during their MND? Yep, I can see some people put their hands up. And some people actually experience weight loss even before they get a diagnosis with MND, before they know anything is wrong. And this is significant because we know that if you do experience weight loss and it's dramatic weight loss, it can actually have a big impact on the course of your MND, the progression of disease. But we also know that if you intervene effectively and you slow weight loss, it can actually, in many cases, slow progression and improve quality of life. And so in 2015, we really wanted to see what's causing weight loss in people with MND. And at the time, there was this idea that the metabolism, how a person's energy is used by the body, changes in MND, and that this itself would actually cause weight loss, which in turn would drive progression of disease. And so we started a study looking at all those factors. And so today I'm just talking about that little bit in the red box, this thing called resting energy expenditure. So resting energy expenditure is the energy we are burning when we're sitting down doing absolutely nothing. 70% of all the energy we consume over the day is burned when we're doing nothing. When we're just sitting still, we don't have food in our stomachs, we're just basically watching TV or something like that. So it's a huge component of the energy we burn. And there was evidence to suggest that in people with MND, this component becomes much, much greater, and that it's specifically seen in people with MND. It's called hypermetabolism. You may have heard of that through other research. So we teamed up with Robert Henderson, who's a neurologist at the RBWH. That's him lying on that couch there. And we built a little bit of a research room. In the far right-hand corner, you can see an egg-shaped thing that's called a bod pod. It's a device that you sit in. It takes 2 or 3 minutes, and when you're sitting in it, it measures your volume, and from that it can tell you how much muscle you have and how much fat you have, which is wonderful because that can give us a prediction of how much energy you should use. And then you spend 20 minutes on the couch under this canopy, and as you just breathe into it, we can actually measure how much energy your body is actually using. And we can compare the two measurements to see if you're using more energy or less energy, and if you're using a lot more energy, we call that being hypermetabolic. Now, this study showed that about 40% of people with MND were hypermetabolic. And that was compared to only about 12% of people who don't have MND. So we call this a dramatic increase in prevalence of hypermetabolism. And when you do the statistics and the numbers, it basically suggests that people with MND were 5 times more likely to be hypermetabolic than somebody who doesn't have MND. So that confirmed all the literature out there to suggest that hypermetabolism is observed in people with MND. Now the question is, how is this relevant? Well, we took these measurements and we compared things like the change in a person's functional score, looking at things like the ALS-FRSR. I'm quite sure that many of you would have done the ALS-FRSR in the past. We also compared it to things like the duration of disease, changes in breathing, and even changes in body composition and body weight. And what we found was that people who were hypermetabolic, so if you have a look at the picture on the left, you want to focus on the pink line, those individuals experience a much faster and steeper decline in their physical function. So in other words, they experience a more aggressive type of disease. And then at the same time, if you look at the picture on the right, those people who were hypermetabolic, they also were more likely to pass away earlier following assessment, suggesting that if you are hypermetabolic, you have a greater risk for earlier death due to MND. In fact, it doubled the risk for death in the first year after the research visit, which was a bit of an alarming observation because it would suggest to us that hypermetabolism does have a big impact on the individual, and potentially this is an area of research that we should focus on to see if we can reduce the burden of hypermetabolism. What was really interesting about this study, however, was we found that hypermetabolism had absolutely nothing to do with body weight. It wasn't associated with changes in weight loss, which would suggest that hypermetabolism outside of weight loss was putting people at greater risk for earlier death. That was important for us because we then moved on and looked at other factors that could contribute to weight loss. And this is where our studies really deviated and we started looking at appetite. And that's something that Jeryn can tell you more about. The other thing was, given that it's an independent risk factor for earlier death, we really need to figure out what causes hypermetabolism in people with MND. And the idea is, once we know what's doing that, can we do something about that to slow down the progression of MND and potentially extend survival? And so that's really what the clinical trial is all about today. Now, I'm not going to tell you about all of the research that we've done to date to try and understand what causes hypermetabolism. Much of it is summarized in this little picture here, and I want to talk about it in detail, but I'm happy to take questions on it. But if you were to summarize 5 years worth of research in the lab and about 5 years worth of research with people with MND, our studies would suggest that at the cellular level, so the muscle itself, the person with MND, we see big changes in how energy is used, and these changes in energy is really measured as hypermetabolism. Specifically, we found that some people with MND turn away from using sugar as an energy source, and they become more dependent on fat as an energy source. Now, this is a bit unusual because as we get older, we would expect to see people becoming less used to sugar as an energy source because they might become more diabetic. But that's not necessarily the case in MND. In this instance, it was almost like muscle was choosing not to use sugar, even though it could use sugar, and preferring to use fat as an energy source. Now, we're not entirely sure why this is the case, but we do have some good ideas, and we believe it's because as the neuron loses connection with the muscle loses its ability to control how it uses energy. Now, that was a very important observation because it kind of gives us an area that we can target to see if we can improve outcomes for people with MND. Now, there are many ways in which you can do it. We had been working with the research team over in France and in Italy for about 5 years in parallel with this study, and we had explored a number of drugs and compounds that could potentially be used to reteach muscle how to use energy in an effective way. And one of these compounds presented some really very positive results, and we were fortunate enough to get funding from Fight MND. And this is really largely driven by my research partner and wife, Shuno. That's a picture of her down there, to to really establish a clinical trial that is run in 3 different sites. Some of you may have heard of it, some of you may have actually participated in it. The clinical trial is conducted here in Brisbane. We also have a team running a part of the clinical trial in Utrecht, and we're hoping to bring a 3rd site online in London. So this is a proper international clinical trial looking at a new drug to treat and slow progression from autoimmune disease. Now, how did we come across this drug? Well, first of all, there are many compounds out there that could do this, but what we wanted to do was really focus on a drug that's already available, something that you can buy, that's been shown to be safe for people. It doesn't necessarily have to be available in Australia, but it must be something that has to be progressed far enough so that if we do show that it works for MND, we're not going to spend 10, 15 years to get it into testing and clinical approval. And the drug we chose was a drug called trimetazidine. It's a drug that's normally used to treat angina. It's not available for sale in Australia. And also there is no evidence to suggest that this drug is safe for people in motor neuron disease. So it has some limitations, but importantly, it does show that if you take this drug in other conditions, it improves how muscles use sugar over fat as an energy source. Now, you may have heard about this drug. Anybody here watched the Beijing 2022 Winter Olympics? No, maybe not. There was a young figure skater who almost got disqualified. She was found to have used a drug to improve her performance. The drug she was using was the same drug, trimetazidine. It's not thought that it would improve performance in a person that young, but a lot of athletes have been banned from using it because what it does is it improves how much oxygen you bring into your muscles, and it improves how your muscles function. So it's considered to be a performance-enhancing drug as well. Okay, so we knew that there was a drug out there that could change muscles use of energy, and we knew that this drug has potential for MND, but we obviously had no evidence for that, and that's when we started working with these other researchers. And again, I'm not going to go through the data in a lot of detail, but what we did do was treat a mouse that has motor neuron disease, a model of motor neuron disease, with this drug. And very importantly, if you look at the first box, we found that the drug improves the metabolic rate. So they used to be hypermetabolic, but after the drug, they were no longer hypermetabolic. So that's really important. We also found that when they were given this drug, that their strength improved, and it stayed improved for much longer. So it improved their physical capacity. And if you look at that third box, you can see that, and this is the green line versus the blue line, the animals that received the drug also lived much longer. They still passed away from motor neuron disease, but we've extended the survival of these animals from 159 days, which is quite normal for this model, to about 175 days. So that's a dramatic extension of lifespan for a little mouse. You should recognize that mice don't live nearly as long as people. So this was a very positive result for us. Anyway, this data was part of the reasoning behind us developing the clinical trial. And like I said, we were very fortunate to get funding from FightMND to start this clinical trial. And Brisbane is currently enrolling people into the trial. And I've got Ange with me today. Ange will actually talk a little bit about what happens when you do join the clinical trial, and I'll present that in just a second. But I just want to stress, this is not a drug trial to see if the drug is going to improve quality of life and slow progression of motor neuron disease. That study needs to be done still. This study is purely to see if the drug is safe. We know the drug is safe in people who don't have motor neuron disease because it's been used for a long time. But when people have motor neuron disease, they present with a number of unique medical challenges. And so by taking this drug and by going out and just buying it and taking it, you might actually put yourself in greater harm's way. And so it's very important that we actually do a safety and tolerability study to show that the drug is effective in some way, but more importantly, that it's not going to do more harm. So for anybody who's watching this and might want to go and buy trimetazidine, please don't do that. I know that you can get it from overseas. We don't know if it is safe just yet. And so we have to do the safety study first. So the primary endpoint for this particular study, as I've just harped on about a little bit, is safety and tolerability. But we're also looking at things like oxidative stress markers, and I can talk more about that if you want to know what that is. But basically, it's just a biological measurement to show that the drug has having an effect on the cells that should benefit the patient. The secondary endpoint is change in energy expenditure. So very much like those mice, we want to show that the drug actually reverses or improves that hypermetabolic state. And then, we're also exploring some potential outcomes sort of to guide our thinking for the next clinical trial, the one where we show that the drug actually improves lifespan and quality of life, assuming it's safe. And that's looking at the association between these oxidative stress markers and things like hypermetabolism, but also clinical progression. So we're looking at whether or not people with MND progress at a slower rate, for example, during the time that they're on the drug, and whether or not they feel better. And Ange can tell a little bit about that if there's questions around that. Very quickly, this is a slide of what's going on there. Let's try that again.
There's a little bit of a connection issue.
There we go. So this is a slide of what the clinical trial looks like. There's a lot on this. So what I'm going to actually do is hand over to Ange, and Ange will tell you what will happen when you join her for the clinical trial.
Good morning, everyone. As you can see, that slide just gives you sort of like a timeline of what the study, how the study evolves. So it's a 20-week trial from start to finish. So we start off with a screening visit, which is up there at visit 1. So we would get you into clinic and do a screening visit, and that involves the bod pod, like Derik showed on the previous slide. We do some other general medical tests, like take some blood, do an ECG and things like that, go through the consenting process and an inclusion-exclusion criteria. So that sort of works out if you're eligible for the study. So we do that visit, and if you do become eligible and you move on to participating in the study, you've got the 7 visits down there, and 5 of those are clinic visits and 2 of those are phone calls. So the first one we get you in, which is the baseline visit, and that's when we actually start the medication. So it's the same process. Those visits, you come in quite early of a morning. We get you in about 8 o'clock. Because we're looking at your metabolism, we want to get you in before you have anything to eat or do anything activity-wise for the day. So we get you in early. It's the same for each visit, so it's always an early visit, always an early start, and we get you in and we do the bod pod at every visit. And then we go through the general visit. So we start your medication on the baseline visit, and that's, you get the medication, you take that home. It's 6 weeks worth, so you're taking that twice a day, morning and night. And then there's a phone call at visit 3 just to check in to see how you're going. And then you come back in for visit 4, which is another clinic visit. And we do the same process again for each of those visits, and we give you a resupply of medication at visit 4 to take home again for another 6 weeks. So you're on medication for 12 weeks for this study. And the last 2 visits are follow-up visits and a closeout visit, which is the same process, but you're off the medication and we're just doing some safety data and collection there for those last 2 visits. And I think that's really about it for those visits all up. Yeah.
So what does a visit look like?
So yeah, so the visit would look like, so it's starting early in the morning, we would come in. It generally takes about 2 to 3 hours for each visit. So we get you in, you're fasting from the night before. As we, like I said, we're looking at your metabolism. So you're coming in fasting. We do all the bod pod. We do some other clinical assessments. We'll give you something to eat during that visit as well. So we will feed you, won't make you starve all day. And go through a lot of questionnaires and things as well. So yeah, it takes about 2 to 3 hours for each of those visits.
And what happens if somebody's coming from, say, far north Queensland?
Yes, so if you do come from far away, you won't be out of pocket. You're never out of pocket for a clinic visit. So there is a chance that we can get you down the night before. We can stay in a motel that's close to the Royal Brisbane, because that's where we are, the Royal Brisbane campus. So you'll be put up in a motel for the night. That won't cost you anything. We'll reimburse you for all those costs. And same if you're coming in just from locally. Once you come in, if you're coming in by a car, we'll provide you with a parking voucher for that day as well, so you will not be out of pocket for those visits.
Okay, and so we can talk about the visit in just a minute. There is something very important to talk about, which is really who can participate in the study, and who should not participate in the study. So, and did you want to talk about the inclusion criteria?
Yeah, so like I was saying, this is done at the screening visit or a little bit before. We can get some information as well. So obviously there's an age limit to the study just for safety. With being hypermetabolic, that's what we find out when you go into the body pod machine, and the parts we work out from those results if you are hypermetabolic. And again, look, being able to swallow tablets, again, just another safety issue with that. So.
And so a lot of people wonder if there are medications like riluzole, if they can participate. So people with medications like riluzole certainly can participate, so that's not an exclusion factor. But there are some drugs that you can't be on when you are in the study, and we'll talk about that in another slide. The other thing is you should be able to lie at least at a 35-degree angle for 30 minutes. So quite often people who are really struggling with breathing can't participate in the study because they can't get through the assessments. That's critical for the outcomes for the study. And then the other thing is you should be able to give consent. And that can be done on the day through a verbal conversation, or it can be done over the phone before you come in as well.
Yes.
Yeah. And then finally, if you're a female, you shouldn't be pregnant when you join the study, and you shouldn't get pregnant during the study, because we are giving you a drug that potentially can impact the pregnancy. So that's the inclusion criteria. The exclusion criteria, there's a lot more text here. Sorry about that. This is really difficult to make this less dense, but you can see there's a lot of exclusion criteria, and we'll talk about those in just a minute. And the reason that the list of exclusion criteria is so big is because this is a safety study. This is a study looking at if the drug is safe. And so obviously we want to remove any variables that's going to potentially cause harm, but also variables that's going to impact whether or not we actually collect data that's meaningful. So if you have a metabolic condition that's going to impact measurements like Hashimoto's or type 2 diabetes, for example, then unfortunately we can't enroll you in the study because we won't be able to tell if the drug has changed your metabolism outside of what MND would normally do to your metabolism. Also, if you have kidney diseases, we can't enroll you because that might have a big impact on how the drug is cleared from the body. If people are on non-invasive ventilation for more than 22 hours a day, we can't enroll you. Because that actually presents with a number of risks that we can't include in the study based on just general monitoring and safety procedures. Obviously, if you can't swallow a pill, then you're unable to take the medication, and so unfortunately we can't have you join us. Although there is a company overseas who's really interested in developing and testing a liquid formulation. So if the study is effective and one day we show that it actually slows progression, then there will be options for liquid formulation. The other one that's really important is people who have hypertension. So a lot of Australians are hypertensive and they're taking hypertensive medications. If you're on a hypertensive medication, unfortunately, then you can't be involved in the study. And then there's a few other conditions as well, but they're less likely to occur. For example, people who have MND plus maybe another neurodegenerative disease, like a neuropathy that's completely independent of motor neuron disease. And again, we can talk about these in more detail if you have any questions about those. So that's the clinical trial itself. Now we have a couple of options. I'm happy to take questions, or we don't just do studies into clinical trials. Like I said, we develop our clinical trials by working with people with MND and doing research that can kind of give us an indication of what's important to the individual and where we can develop therapies and treatments to improve quality of life for everybody. And so we are more than happy to also talk about these other studies and how you might get involved. I think, given that Jeryn is with us today, the one study that might be most interesting to talk about is the BELONG study. It's the only study of this kind in Australia. It's one of the few studies in the world that actually include people with PLS and PMA as a priority. This study was really designed to more closely work with people with slow progressing forms of MND. And so I personally feel that this might be the kind of study that's more applicable to people who are, interested in research but don't want to come every 3 months for a research visit. And I think we'll leave it there for questions.
Sure.
Yep.
Any questions? You can unmute yourself now, yeah.
I have a question. Does this have any implications for what is actually going on? Does, for example, is the enzyme that you're inhibiting, is it upregulated in people with hypermetabolism, motor neuron disease, or is the ability to use glucose, in fact, downregulated or inhibited in some way, and the use of fat is there to compensate for a problem with glucose metabolism?
Yeah. So correct me if I go from the wrong tangent, but the studies we've done so far to study how the person with MND is using sugar and fat is mirrored by studies we've done on mice as well. It's very difficult to do these studies in people because what we have to do is take biopsies of tissues and study those tissues. But in the mice, we've actually found that there is a switch in the muscle to preferentially use fat over sugar, but the muscle doesn't become incapable of using sugar. So it's not like the muscle will become like a diabetic muscle where things like insulin is not, clearing sugar from circulation, or things like the glucose transporter that would normally take sugar into the muscle is not functioning. But there are some deficits that occur at the level of the cell. For example, there's changes in this enzyme called phosphofructase kinase, and I'm not going to go into a lot of the details with that. But what we have found is when we treat animals with this particular drug, what happens is it actually encourages the muscle. It's a partial fatty acid inhibitor. It's not a complete fatty acid inhibitor. It kind of forces the muscle to rely more on sugar because it doesn't necessarily have access to the fat as its primary energy source. And this in itself seems to have those beneficial effects. One of the byproducts of using fat as an energy source is that you consume more oxygen, which is probably why we're seeing hypermetabolism. And one of the byproducts of that is the production of what we call reactive oxygen species. These are kind of byproducts of burning energy that, if it builds up in the muscle, can have detrimental effects. And so what we think, and we haven't got evidence to confirm this, is that part of why this drug is so beneficial is because it also lowers the production of those reactive oxygen species. And that's kind of why we've included a lot of the oxidative markers in our study to see whether or not the drug itself is improving that. That's kind of the exploratory component. Does that answer the question?
I mean, sort of. I mean, you still don't know exactly what's going on, why it happens, why the switch occurs.
Yeah. We don't know why the switch occurs. We are doing those studies at the moment. So over the last 5 years, we've collected a number of muscle biopsies from people with MND, and we're studying those muscle biopsies in different ways. But we've also collected skin biopsies from people, and we use those skin biopsies to drive neurons, generate neurons from people with MND. And we're using those two kinds of tissues to kind of look at why this occurs. And all of the results so far would suggest it's something inherent to what we call the mitochondria, that little cell that sits within the organelle, within the organelle that sits within the cell that uses energy and generates energy for the cell. But exactly what's happening? No, we are still working on that one.
And is there any evidence that the ability to store and then use glycogen is affected in MND?
Yeah, so there is some evidence from a collaborator looking at mice again, and they focus predominantly on glycogen, and I can direct you to that research group if you want to have a specific conversation. We haven't seen that same effect in our patient samples, and I think that's because people with MND are so different. And it's so variable, and so you're not seeing a strong signal. So I personally think that in some people it is important, but I think that as a group of patients, it's not an overwhelming change. And so I don't think that it's glycogen. I actually think that it's more the mitochondria of the individual. And the other reason for thinking that it's more mitochondria is because we've understood that mitochondrial dysfunction has been part of MND for a very long time now.
Any more questions?
Yeah, I have a question if you don't mind.
Yeah, absolutely.
There's different weight types, like for instance, fat versus thin. Do they have a factor on MND on how fast you get between hyper and that?
So when we first started our research, and I might go to that slide and see if I can find it for you, we were actually interested in the fact that people who are overweight tend to have a very different course of disease. They are more likely to present with MND later in life, and then when they do get MND, they have a slower course of disease. And so things like having a decrease in body weight increases likelihood of having a more aggressive disease. We found that decreases in your body mass index. Everybody uses BMI these days, which we think is a terrible measurement in people with MND, because people with MND lose muscle, and BMI itself is the factor of muscle. But generally speaking, BMI correlates with poor prognosis. And then, of course, if you look at BMI, we think of things like fat-free mass and fat mass. People who lose fat-free mass faster also have shorter survival. That kind of makes sense. That means that the muscle is more aggressively affected. But what we also found is that people who lose their fat faster have more rapid progressing. And if you have greater fat mass, you actually have a better outcome. So it's all been about maintaining that positive energy balance. Now, there was a study done by our collaborators in France where they actually put people with MND on a high-fat diet to see if that would slow down progression. And they found that it only makes a difference in people who would have lost fat anyway. So those people with a more aggressive type of MND.
So bulk foods won't help somebody with MND, like sumo wrestlers bulk up on particular types of food just to get some more body fat on them.
Yeah, so I personally think that the answer is to work very closely with a dietitian that's MND focused, to maintain body weight. There are unfortunate side effects of gaining too much weight, which is, you become heavier, and as you become weaker and you become heavier, it's going to have a big impact on your physical ability to get around. And so, excess weight gain is also not necessarily a good idea. And so working with a dietitian to maintain weight is probably the best strategy.
Okay, and one last question, if you don't mind. People that have the slow MND, can they change from slow to fast, or can fast change back to slow?
Yeah, so we work with a group here in Brisbane called SALSA. I don't know if you're familiar with SALSA. It's basically researchers collecting information from people with MND all over Australia. And recently I looked at some of their data, and they found that in Queenslanders especially, who were included in the data set because there are many Queenslanders in the data set, they had slow progressing MND, and then suddenly they saw a change in the rate of progression. And from their data, it was actually people with the what we call flail limb MND, so progressive muscle atrophy, and they would be stable for many, many years, and then suddenly there's an acceleration in the rate of their progression. I've not really seen it so much in people with PLS, but I have heard reports of that in people with PLS, and it's quite often something underlying that has changed. Maybe their level of care, or maybe they've had a period of illness. And that kind of makes sense because we have this thing called the physiological reserve. I don't know if you've heard of that. Physiological reserve is kind of the ability our body has to deal with disease or environment. And every time we get sick, that kind of drops. And then over time, it kind of recovers, but it never comes back to 100%. And our goal is to maintain our physiological reserve, so when we get sick, we can deal with it. And I think for people with PLS and PMA and all these diseases, over time that reserve gets depleted, but the ability to build it back up again is compromised. And so, a significant insult like a period in the hospital, you take longer to recover from that. but also it's very likely that these are the insults that then change the course of MND. One of the purposes of the BELONG study is really to understand that more detail. And so we are enrolling people with PLS and PMA in that study, and we are following them over a period of, is it 12 to 18 months, Jeryn?
Yeah, roughly. Well, yes, 6 to 12 months.
6 to 12 months.
Mm.
So we're following them for 6 to 12 months to actually collect information on that. But obviously, if somebody is diagnosed with PLS, then really we should be following them for 5 to 10 years instead. And we've got the databases and the infrastructure now to be able to do so.
Okay, thank you. That's all for me. Thank you.
Any more questions?
So, yes, I think there was one. I might, if you don't mind, we do have a few minutes, and I think I might just get Jeryn to tell everybody a little bit what the BELONG study looks like.
I think that'd be great.
Yeah?
Yeah, absolutely.
Yeah, sure. So I'm working with another researcher at UQ, Dr. Tom Shaw, and the BELONG study is an imaging study. So we're using MRI to look at changes in your brain and spinal cord. So I'm sure most of you have been inside an MRI machine. Essentially, we're interested in the longer forms of MND. We still don't quite know what is contributing to some people with MND having a longer surviving form versus shorter surviving form, as Derik has mentioned. And so we're interested in seeing whether or not there's something in the spinal cord of the brain that might be contributing to that. So whether or not there's any biomarkers that we can detect. And so as part of BELONG, we're also, as Derik mentioned, we're looking at whether or not there's longitudinal changes over time as well. And so that's why we ask participants to come back 6 to 12 months later from their baseline visit, just to see if there's any changes as well.
So are these just standard MRI scans?
Yeah, pretty much. We're looking at the differences in structure, this is different to your standard brain MRI scan. So we're looking at your spinal cord as well. So we also you also fly through the MRI machine, one thing about the BELONG study is that you need to be able to lie completely flat in the MRI machine for about an hour or so. So that is a limitation as well. So
I guess it's an ambitious thing to scan a person's spinal cord because there are unique challenges with it, which is probably why it's not done very often.
It's not, yeah. This is quite a novel study. Yeah.
Can I ask a question?
Yeah.
So what are you hoping to inform from the outcomes in terms of longitudinal studies? So you're looking for biomarkers. Is that to help with management or treatment or cure?
So when we developed the BELONG study, the idea was that each person with MND and each different type of MND will present with a very unique structural change in the spinal cord that might be picked up by some of these experimental scans. And the idea then is to scan people more than once to then match that to their progression to see how those structural changes might have occurred over time. And then the idea is to work that back. So if you go to a clinic, you might get an MRI scan as part of your diagnosis process. You might get given a diagnosis of possible probable ALS, but then you really wouldn't know. You come back for your second scan, and then there might be a biomarker. They say, well, actually, you have PLS, so you can expect a slower course of disease, and these are the challenges that will face you versus, well, we can confirm that you have ALS, and these are the challenges. So the idea is to actually improve diagnosis early on.
Okay. That's great. Anybody else have questions?
So I will finish by saying, I mean, obviously our focus today is to just tell you about the research so that people know that it is happening. There are about 7 clinical trials that's currently being run out of the RBWH for people with MND. Obviously, not all of those clinical trials are actively recruiting right now. These clinical trials may not be suited for everyone. But if you are interested in clinical trials or you want to get involved with observational research, maybe you're very keen just to sit down and talk to some researchers or just get involved, my suggestion would be to contact MNDAQ. Yeah. And I'm sure you guys will happily pass your information on.
Do you have your contact information you want to put on the screen?
Yeah, although I think given that we're here to promote research overall, yeah, what will happen is I will actually connect you directly with the research clinic. Okay. Every Thursday at 1 o'clock, we run a research clinic at the RBWH. People can join it via Zoom or in person. We then talk about all the research that's being done here at the University of Queensland, but also at the RBWH. And we also talk about all the clinical trials that's available. We then send people home with a list of all the clinical trials that might be suitable for them, but also information on all the observational studies they might want to get involved with. And then if they're happy to proceed at that point, we basically get you involved in all those research studies.
I think I just had a comment.
I think the question was emotional.
Emotions are the cause of all illness and disease.
I think that emotions certainly are involved in illness and disease because illness and disease definitely impact emotion.
Absolutely.
We know that in MND, your genetics kind of set you up for getting MND. We still don't know what actually drives that change. So something in combination with genetics. So I'm not going to discount the role of emotions. But I certainly think that MND impacts emotions.
Yeah, absolutely. Yeah, I agree with that.
And it might even impact it before you present with significant motor symptoms. Yeah.
Do you have any other questions or comments?
Is there any evidence that methylation of mitochondrial DNA occurs?
Oh, that's a really good question. And I'll be honest with you, I don't know the answer. We looked into that a few years back and there was no evidence for that at the time, but I haven't looked at it in the last 2 or 3 years, so I can't say if anything has changed then. That's a very good question. I guess in a way we can argue that maybe it has a role to play, but not dramatically, because we know that family histories of MND runs both the mother and the father's side. But yeah, I don't know. I'll have a look. I have to have a look.
Good question, Andrew.
Have you come across anything, Andrew?
No, but I just know in some diseases like cancer or whatever, methylation of nuclear DNA occurs, and there was some evidence that it occurs in mitochondrial DNA, but MND wasn't included in the list of diseases I saw.
No. So one of the things that we're looking at is methylation of a particular gene that drives the activity of a particular enzyme that we believe is actually what predisposes to hypermetabolism. So we actually think that methylation and lifetime changes in the activity of genes might have an impact on how the disease progresses. But whether or not it actually causes MND, I don't know. Yeah.
And asking questions is really important. So if you do have any questions when you are talking to any researchers, it's more than encouraged.
Yes, absolutely. Yeah, most of the research we're doing today is actually through the discussions we had with people with MND, and they've had a big impact on where we focus our research. For example, we would not have been focusing on appetite if it wasn't for the feedback we got from people telling us that their appetite has changed, and it might not have lost their appetite, but they've certainly changed their preference for foods, or even their taste has changed, and that kind of has led to a lot of work we're doing now.
All right, any more questions or comments?
Yeah, just one more if you don't mind, please. You said that everyone with MND is different in their disease. but is there anything that is common to everyone?
That's a good question. So yes, there are some things that are common. So we know that about 95% of people with MND have a type of proteinopathy that is defined by a particular protein called TDP-43. So most people with MND have that protein that's gone outside of where it should be in the cell. But that's only 95%. Some people with MND don't have that protein, for example. So even the most common feature of MND is not universal to everyone with MND. So current thinking is that MND is a disease that is caused by genetics for everybody. And there's no evidence to say that's the case, but there's good evidence to suggest that genetics has a big role to play in risk. And it's not just necessarily one gene. It could also be a unique combination of genes that have small effects. And this is not actually unique to MND. This is unique to most diseases with a genetic predisposition. So maybe that's the only thing that's unique, or well, that's not unique, that is common with everyone else. But other than that, I've not come across anything that is shared by everyone with motor neuron disease.
Okay, what about lifestyle? Now, I read somewhere in England, they actually did a survey of people with MND with their lifestyle, and they found that the majority of people, or a lot of the people, were farmers because they actually worked on the land that had MND. So I was just wondering whether lifestyle or something, whether you've done any studies on lifestyle, whether the
So again, I do encourage you to connect with us through the research clinic, because one of the groups we work with are actually currently running an online lifestyle questionnaire to collect information on Australians to see which lifestyle factors are more likely to be associated with increased risk for MND. We have to be very careful about lifestyle because we have infinite exposures throughout our lives that can impact us in different ways. For example, and I just saw the question on exercise, a lot of people say that there is an association between exercise and MND, and a lot of people see all these sports stars, you know, very fit, healthy individuals develop MND. It doesn't mean that their exercise caused their MND. It might just be that they were carrying a genetic predisposition based on a unique set of genes, and that them exercising had an impact on their likelihood of developing MND. We have to remember that the motor neuron, the neuron that is dying in MND, is a unique cell that you're born with and that will die when you die. It doesn't regrow, you can't replace them. And so those are the cells in our bodies that are most likely going to show something happen to them if they die, because you can't replace them. And so those are the cells that are most vulnerable. If you have a genetic predisposition that puts these cells at risk, doesn't matter what you do throughout your life, if it's going to impact it negatively, it will die and it presents with MND. And it might be things like exercise that puts them at greater risk. But it doesn't mean that everyone should stop exercising because not everybody will carry that risk.
Do we have any more questions about the current studies that were talked about today? No? Well, thank you so much for your presentation, for talking about the studies, and for imparting so much amazing knowledge. So I've gained a lot of knowledge from today and a lot of valuable information. I'm sure everybody has as well. If you guys do have questions afterwards, feel free to email us and we'll pass them on in terms of in relation to the studies that were talked about today. But I do encourage everyone to attend the research clinic, even if it's just to get an idea of what's out there. That's totally fine. And imparting your knowledge and your experience of MND is quite critical to research. So I do encourage you to get involved.
And like I said, you know, being involved in research is not expected from everybody, but it might benefit you in some way, even if it's just to share your ideas and thinking. There is no expectation for people to actually do research if they attend a research clinic. It's more of a fact-finding exercise for them. And then if they happen to like the research that they spoke to, at that point they can join. You're welcome to withdraw from research at any point. You're even able to pick and choose what research you do. It's entirely up to the individual.
Absolutely. That's an amazing point to bring up. Yeah. All right. Well, thank you, everybody.
Thank you.
Thanks for joining us.